We need to talk about an uncomfortable paradox in pediatric medicine. The antibiotics we use to treat recurrent urinary tract infections in children may actually be increasing their kidney stone risk. This creates a vicious cycle that's difficult to break and highlights the unintended consequences of our treatment approaches. Let me explain the mechanism clearly. Antibiotics kill bacteria indiscriminately, not just the pathogens causing infection, but also beneficial gut bacteria. One particular species, Oxalobacter formigenes, lives in the intestine and degrades dietary oxalate. When repeated antibiotic courses eliminate this bacteria, the gut loses its ability to break down oxalate from food. This disrupted microbiome increases oxalate absorption from the intestine. That oxalate enters the bloodstream, gets filtered by the kidneys, and appears in urine at elevated concentrations. High urinary oxalate drives calcium oxalate stone formation, the most common type of kidney stone. The vicious cycle I'm seeing is deeply troubling. A child has anatomical abnormalities or voiding dysfunction causing recurrent urinary tract infections. Each infection requires antibiotic treatment. The cumulative antibiotic exposure progressively damages the gut microbiome. Gut dysbiosis increases oxalate absorption and stone risk. Now the child has both recurrent UTIs and kidney stones, compounding their urinary tract problems. Prevention strategies need to focus on breaking this cycle. We must identify and correct underlying causes of recurrent UTI rather than just treating each infection as it occurs. Vesicoureteral reflux, where urine flows backward from bladder to kidneys, can be corrected surgically. Dysfunctional elimination, behavioral patterns of incomplete bladder emptying or chronic constipation, can be addressed through behavioral interventions. Prophylactic approaches using low-dose antibiotics or alternative strategies might reduce infection frequency. When antibiotics are necessary, selecting microbiome-sparing options minimizes collateral damage to beneficial bacteria. Post-antibiotic recovery protocols matter enormously. Probiotic supplementation after antibiotic courses makes theoretical sense, though I must note the evidence for successfully restoring Oxalobacter specifically is mixed. We don't yet have proven protocols for recolonization. Dietary modifications during the vulnerable period after antibiotics can reduce oxalate intake while the microbiome recovers. For high-risk children, monitoring urinary oxalate levels allows early detection of problematic elevation. The diagnostic challenge complicates everything. Distinguishing UTI symptoms from kidney stone symptoms is difficult because they overlap substantially, both cause pain, urinary frequency, and urgency. When a child presents with these symptoms and has a history of both conditions, comprehensive workup becomes necessary rather than assuming recurrence of whichever problem they've had before. Antibiotic stewardship becomes critical in this context. We must balance the genuine necessity of treating infections against the real harm of microbiome damage. This means confirming infections with proper testing before prescribing, using narrow-spectrum antibiotics when possible, and exploring alternative prevention strategies. Behavioral interventions for dysfunctional elimination, surgical correction of anatomical problems, and cranberry products for infection prevention all have roles in reducing antibiotic dependence. The broader message is sobering. Our treatments have consequences beyond their intended effects. Antibiotics save lives and prevent serious complications from infections, but they're not without cost. In children with recurrent UTIs, we need comprehensive approaches addressing root causes rather than reflexively reaching for antibiotics with each new infection, inadvertently creating kidney stone risk in the process.